Okay, we're going to go on to case number 5 with a confused and irritable 73-year-old woman with insulin-requiring diabetes mellitus is brought to the emergency department by her family for a flu-like illness earlier in the week and because she's not been eating well. Okay? Confusion, irritable, something going on for about a week. Over the past 24 hours, but she's an any confused insulin-requiring diabetic or any confused diabetic on oral hypoglycemic agents, what's my most likely diagnosis? What's most likely diagnoses 1 through 10? Do they have an insulinoma? Do they have head trauma? No, they're hypoglycemic. It's one of the costs you pay for taking things to keep your sugar low is your sugar goes too low. Happens in every diabetic who's on some therapy some of the time. All right? It's rare that you have someone who's a diabetic on some form of either oral or injection therapy who isn't hypoglycemic some of the time. So that should always strike you as the most likely etiology. Let's go back to the case. This morning she's been difficult to awaken. All right, so something is progressive now. There's no history of fever. Do we think she's been hypoglycemic for this whole past week? Do most people who are hypoglycemic hang around hypoglycemic for a week? No. It's usually more of an acute episode. Things get severe enough that they get medical attention and it's detected. So it might be that something else is going on for the week and now she's hypoglycemic. In fact, if someone has a stable regimen of either oral hypoglycemic agents or insulin and now they're hypoglycemic, you should always ask yourself, well, what's different? Did the patient eat less? Did the patient inadvertently take too much of their medication? Or is there some other process that causes the sugar to go down? All right? And maybe that other process is an infection, and maybe that, quote, flu-like illness is what's triggering this whole problem. But again, hypoglycemia, when it presents to you on the boards, is usually going to be an acute event. There is no history of fever, neck stiffness, or focal neurologic deficit. What is that suggesting to me? She probably doesn't have meningitis. An old lady, diabetic, change in mental status, confused, now lethargic. Do I have to at least consider bacterial meningitis? Yes. The fact that she doesn't have any fever, neck stiffness, or focal neurologic deficits makes me feel better about the possibility of meningitis. Does it exclude the possibility of meningitis? No. On the other hand, is this history typical for acute bacterial meningitis? A history of 1 week? No. Bacterial meningitis is usually hours, maybe a day, 48 hours, I would say tops. Okay? Vital signs, temperature, 100.0 or 37.8. Blood pressure, okay, she's tachycardic. Respiratory rate, 16. Pupils, okay. Normal heart sounds, she's tachycardic. Normal lungs, normal abdomen. She has some venous stasis changes in the lower extremities. Neurologic exam, non-focal, no gross deficits. However, she's unable to follow commands. And let's say I add to that, obviously, she does not seem to be fully alert, etc. So what am I concerned about here? Obviously, hypoglycemia. What would be your first step in the evaluation and management of this patient? Finger stick. You'll know in a few seconds, literally within seconds, whether this patient is hypoglycemic. All right? So, again, every diabetic who's confused, worry about hypoglycemia as the cause. Can they have other causes? Sure, they're more prone to infection. Sure, if they're hypoglycemic, maybe they fell down while they were a little bit less alert than usual, now have a subdural hematoma. But always put hypoglycemia on your list of any patient on the boards who presents with a change in mental status if they're not given any additional history. All right? Certainly in a diabetic, you're going to worry about hypoglycemia. All right? But if you're told someone's found on the street and no history is available, and the question goes out of their way to tell you that you have no history, no knowledge of their past medical history, hypoglycemia should be on your list because there are so many diabetics walking around out there, and because this is such a life-threatening problem, and because it is so easily fixable. In fact, and I probably should have mentioned this in the first case, we'll discuss it now, is part of our therapies that we give every patient who has a change in mental status, who comes to the emergency room, or is found by the emergency medical technicians, is designed to address hypoglycemia. Because generally we give them what we call a cocktail. All right? Cocktail means a mixture of drinks. In this case, the drinks you're getting are going to be things designed to correct fixable problems that can cause change in mental status, such as hypoglycemia. How do I fix that? Give you a shot of glucose. Or if you're awake enough, maybe just give you some glucose to drink, something sweet. Number two, what else can make you acutely change in consciousness? Well, alcohol, yes, but I have nothing that I could reverse the alcohol right away. What else? Narcotics. So part of the cocktail I give everyone besides sugar, in case they're hypoglycemic, is naloxone, a specific narcotic antagonist. So if you're laying there unconscious because you just shot some heroin, or smoked heroin, or any other way that you got heroin into you, then that will immediately wake you up. It might wake you up so much that it puts you in acute withdrawal, but that's a separate issue. All right? So we have hypoglycemia. We're giving the patient some intravenous dextrose. Number two is we're giving some naloxone injection. What's number three in our, quote, cocktail? Thiamine, for the reasons we discussed in the first case. Maybe this is an acute Wernicke encephalopathy. If I find the next 100 patients I'm going to find on the street, well, they're not patients yet. Well, they're patients when I find them. Next 100 people I pass on the street who are unconscious, and we're here filming in New York, so by the time I walk from 4th Street to 8th Street, I'll probably see about 100 people unconscious. What will be the most likely etiology? Will Wernicke's encephalopathy be the most common cause for the next 100 unconscious people I find on the street without prior medical histories? No. Most of them will probably be narcotic overdose or some other substance abuse. The rest might be hypoglycemics. Only a small number do we actually find true Wernicke-Korsakoff encephalopathy. But, on the other hand, it's so easy to fix. There's no risk to giving thiamine. It's so cheap that our cocktail has become glucose, naloxone, and thiamine. All right? And emergency medical technicians don't need to call up a base station where there are physicians to automatically give that, because there's really no harm. Now, is that true? Is there really no harm? Well, if I give thiamine, there truly is no harm. There's no such thing as an acute thiamine overdose. Okay? You don't become super healthy. But if I give sugar, is that potentially harmful? Let's say this diabetic, this one in particular, has as her cause of confusion not hypoglycemia, but massive hyperglycemia as part of non-ketotic hyperosmolar or coma. Or if she's a diabetic who takes insulin, maybe it's DKA, although it's not. 73-year-olds don't usually present with DKA. All right? Will I do that patient any good by giving her glucose if her sugar's 300, 500, 800? Obviously not. Am I doing the patient some harm? Yes, some harm. But the risk of making her worse from going from 500 to 700 with some D50, it's worth taking that risk in case she really is hypoglycemic and I have no way of checking her sugar. Obviously, the nicest thing would be just check her sugar with a finger stick in 60 seconds, know which way she is. But if she's hypoglycemic, I'm going to give her the D50. D50 meaning 50% dextrose. If I don't know what her sugar is, I'll take the chance and give her the dextrose, because I'll do her a little bit of harm if she's hyperglycemic already, but I'll do her tremendous good if she's truly hypoglycemic. All right? And Narcan, naloxone, the brand name is Narcan. Is it absolutely safe? No, it's not absolutely safe at all. People who are passing out on the street from heroin overdose, it's not necessarily the first time they've shot heroin. They may be shooting heroin 4 times a day for the last 20 years. Now you give them something to reverse acutely that heroin overdose, and they'll go into an acute withdrawal syndrome. And they'll even seize. But that's the risk you got to take. If they have narcotic overdose to the point that they're unconscious, that implies also severe respiratory depression, you have to do something to wake them up. And that's naloxone. All right? So our standard cocktail for a patient with a change in mental status, from whom the question gives us no past medical history, no medication list. Of course, they might give you some clues to lean you towards narcotic overdose or hypoglycemia, etc. But if they don't, we'll sort of blindly give them sugar, naloxone, and thiamine. Okay, so this patient, we do a measurement of blood glucose by finger stick, and from this history alone, can I predict with confidence whether her sugar will be 35 or 735? Can I tell from this in clinical information? The answer is, well, if there is, let me know, because I'm not sure how to tell. Because she could have an infection for the last week, which might make her prone to hypoglycemia or hyperglycemia. Okay? The body's glucose homeostasis can vary in either way, all right, for various pathophysiologic reasons. But certainly, more commonly, is that they'll get hyperglycemic. But can I know for sure she's not hypoglycemic? No. The presentation is similar. Sure, if the question wants to tell me that she's had a lot of polyuria and a lot of polydipsia, that would imply that she's been running around with high sugars, and that's why she has an osmotic diuresis and she's peeing so much. If I don't get any of that kind of information, it could be hypo, it could be hyper. I'll do a finger stick if that's available to me, and I'll know what her sugar is. And then, what do? She's hypoglycemic. Obviously, the next step is place intravenous catheter. What kind of fluids do you want to put in? 50% dextrose water, all right? And that'll wake her up within minutes, all right? Then, are you finished? End of case? No, the question, if this is a CCS, it probably won't be the end of the case. Because they want you to say, well, why is this woman now, who's been on a stable regimen, who's alert, maybe she lives with her family, it sounds like, why should she all of a sudden have a change in her glucose? She hasn't changed her insulin regimen. There's people there who can monitor her to make sure she's taking it the right way. What's changed? Well, she has a flu-like illness for the last week. So she has some triggering cause for a change in her glucose homeostasis. So your job now is to figure out where she has a pneumonia. Where she has an infection. Okay? From the question, do I have any signs or symptoms of a specific infection? No. All right? I'm going to do all the usual things on my evaluation to make sure there's no obvious, which I've already done, no obvious pneumonia, no obvious meningitis, no obvious urinary tract infection or pyelonephritis in a diabetic, no obvious cellulitis. Okay? All of those, I don't have any evidence for any of those. And maybe a flu-like illness is just a flu-like illness. But again, any patient who's diabetic who presents with DKA or non-ketotic hyperosmolar coma or hypoglycemia, you have to ask, why is something different now? The most common reason for hypoglycemia is people didn't eat soon enough. Okay? So again, or they're exercising and have not increased their amount of carbohydrate intake, and so they're burning up more sugar. Okay? But always ask yourself, especially in the older patient, is this patient infected? Or another possibility is this patient having myocardial ischemia, and maybe because they have silent ischemia, because they're diabetic, maybe that's the only manifestation is your hypoglycemia. Okay? So again, always think about hypoglycemia in a patient who's unconscious, particularly if they're insulin-dependent diabetic, or even if they're taking oral hypoglycemics agents. And then ask yourself, why the change now? All right? And you'll usually have the information by history or physical. Okay. Let's move on to our next question. Chief complaint. I'm spitting all the time and I'm tired. All right. Any diagnosis leap to mind already? No, obviously not. 60-year-old farmer is brought to the emergency department because of excessive salivation and somnolence. Now, that's not a common combination. I mean, I'm somnolent most of the time, but I'm not spitting most of the time. When I'm spitting, I'm not usually somnolent. All right? So that's a funny combination. And that particular combination should make you think of an overdose and a particular kind of overdose. And this guy is a farmer. And again, very often the question will tell you what this person does for an occupation or for a living, how they spend their time. Sometimes it may have absolutely nothing to do with their problem, or it may have everything to do with their problem. Okay? After spraying his crops, somnolence and spitting. Oh, my differential is not very long anymore. He develops diarrhea, polyuria, and excessive salivation. Oh, it's obvious. He has ulcerative colitis, diabetes, and a salivary gland tumor. Of course not. This is a classic presentation of something that causes lots of secretions. Secretions in your mouth, secretions in your GI tract, secretions in your GU tract. All right? What causes secretions? Or conversely, what dries you up? What dries you up in general are anticholinergic agents. And we know this because when we give our patients drugs with anticholinergic properties, they'll call us up and say, Doc, this antidepressant you gave me called amitriptyline, you know, I can't go to the bathroom anymore. I can't move my bowels. My mouth is dry all the time. Or you give the phenothiazines to patients, and they say, you know what, I'm less schizophrenic, I feel great, those voices aren't talking to me all the time anymore, but I can't move my bowels, my mouth is dry all the time. Anticholinergics, you probably know, dry you up. Whereas a cholinergic event, and we don't have cholinergic drugs, we don't have drugs that for the most part stimulate cholinergic secretion. So it's rarely a drug effect unless the drug happens to be a pesticide or an organophosphate toxicity patient. Okay? Now, you don't need to be a mid-farmer in the Midwest. Do we here in metropolitan urban New York see patients with this? Sure, they're in pesticides. And we spray our gardens, and we could inhale this. And it's easily absorbed, not only inhalation, but from skin. And it can cause this clinical syndrome. And very few things cause a cholinergic-like scenario. And this is obviously one of them. Vital signs, 37, blood pressure, low, pulse, slow, and respirations, 24. Pulse. You would think with all this activity, diarrhea, peeing, spitting, that everything's speeded up, that there should be a fast heart rate. Obviously, this is not an issue of everything speeded up. This is not a hyperthyroid patient, all right? The hyperthyroid patients get somnolent, or they get, all right? They get hyper. That's why they call it hyperthyroid, all right? They don't spit, okay? They don't sleep. They don't get bradycardic, all right? Bradycardia, with all that other secretion stuff, again, fits with cholinergic tone. Remember, your vagal nerve, what does it do in your heart? It's mediate, what neurotransmitters there? Cholinergic. Vagal tone, I squeeze your carotids, I squeeze your eyeballs, I make you Valsalva, I increase your vagal tone, your vagus nerve releases more acetylcholine, your heart rate slows down. All right? So I could use cholinergic tricks to slow your heart rate down. If you have a supraventricular tachycardia, I'll press on your carotid, hopefully not two at a time, because that'll slow everything down. Press on a carotid, get vagal tone, lowers your heart rate. This patient has too much vagal tone. They have too much cholinergic tone, all right? And that's why their heart rate is slow. Okay. He appears to be somnolent in mild respiratory distress. His skin is warm and dry. Physical examination shows meiosis, wheezing bilaterally, and a soft abdomen with hyperactive bowel sounds. Wheezing. Is this aspiration pneumonia? Somnolent, maybe aspirated? Maybe he fell asleep in the field and he aspirated something. Does that fit? What's the more likely explanation for bronchospasm in a patient who you feel so strongly at this point has an organophosphate poisoning? Why is he wheezing? Think back of step 1 and step 2. A little pathophysiology. What does cholinergics do in the lungs? Well, say, wait a second. I remember we use anticholinergics as therapy for asthma. We use ipratropium in an inhaled form. We even used to use atropine and sometimes still do in a nebulizer form. I want anticholinergics for my asthmatic because that means that anticholinergics cause bronchodilation because cholinergic tone causes bronchoconstriction. All right? So again, this cholinergic tone will cause bronchoconstriction, and that is again very consistent, very classic with this kind of poisoning. Okay. Neurological examination is non-focal but shows lethargy. All right, so this is obviously an organophosphate poisoning and what we call a cholinergic crisis. Not many other things in the universe will present like this. Okay? Now, what is the mechanism of action? They inhibit acetylcholinesterase, right? So acetylcholinesterase inhibition. You got two negatives. Acetylcholinesterase, right? That's what breaks down acetylcholine, and I'm inhibiting that. So I got more acetylcholine hanging around. All right? So what do? Well, I want to decrease cholinergic tone. So if the patient is hemodynamically unstable from bradycardia, for instance, I would use atropine. Okay? And atropine would reverse a lot of the effects of the other manifestations. But remember, nobody ever died because they were spitting too much. Okay? I don't need to use atropine too casually. What's the side effect of giving atropine? I could give you tachycardia very quickly. All right? Then I got to worry about pressing on your sinus, and then on the other hand, giving you some atropine. You're swinging back and forth. So again, you have to think about when is the patient severe enough to require atropine. If they're having a little bit of diarrhea and they're spitting a little more than usual, that's not exactly a crisis. All right? But if they have severe symptoms in the cholinergic crisis, they'll be bradycardic to the point of being hypotensive. So there, certainly, atropine is indicated. The specific agent we also sometimes use is pralidoxime, which we give in any patient who is hemodynamically unstable, and that will release some of this organophosphate which has bound to your acetylcholinesterase, okay, and reverse the organophosphate poisoning. So the key is the clinical presentation will be very classic. For cholinergic tone is very increased. It will be a pesticide. The question will clearly give you some way that the patient has had a pesticide exposure. All right? If this person has no pesticide exposure, don't make the diagnosis of organophosphate poisoning or a cholinergic crisis. It's probably something else you're missing. The question will almost always give you some reason to suspect that there's an exposure to pesticides. Okay, let's go on to the next case. Patient who has sudden shortness of breath. She's a 35-year-old woman, comes to the emergency department with progressive shortness of breath that began last evening after dinner. Progressive shortness of breath since dinner. Bad enough to come to the emergency room. Acute onset. That's a little funny presentation for someone who's eating dinner to get short of breath. Acute bronchopneumonia, maybe. Asthma. I don't hear anything about wheezing so far. I mean, this is a little peculiar to start with. She has a non-productive cough and pain on her right side with inspiration. Asthma, usually not one side. Could asthma give me pleuritis? Pain with inspiration? Yeah. Could this be bronchopneumonia still? Maybe. Acute onset, young person. Can they get bronchopneumonia in the community? Yeah. That's so far the most likely cause. This morning she awoke with a fever. Fever, pneumonia, simple. And coughed up a scant amount of blood-streaked sputum. Sure, sputum, fever, acute onset, focal findings, pleuritic symptoms. Sounds like a pneumonia, right? Healthy 36-year-old woman so far. She recently returned from vacation in Australia. Sure, Australia's a nice place to go. Nothing wrong with that. Any opportunistic infections in Australia? Does she have acute tuberculosis? Did she pick up some bizarre Australian bug? Any kangaroo-related illnesses? I can't think of any. Why do they put this in the question? Australia. All right? The boards expect you to be very cultured and have vast knowledges of information outside of medicine. In this case, geography. Where is Australia? Far away. That's all I know. Somewhere over there. All right? We're here. Australia is over there. And I don't think she came by boat because that would take her about 6 months. Most people come back from Australia by plane. And it's over there, it's far over there. That ain't a 2-hour trip. That's a 12-hour trip or 18-hour trip or 24-hour trip. All right? Doesn't matter if you're taking this test on the East Coast or on the West Coast. You could be sitting in New York or L.A. One way is less time than the other, but it's still going to be lots and lots of hours to get back from Australia. So what does that mean? She caught a cold on the plane? That's possible, actually. We all get off planes. We think we caught something from all that circulating viruses that are circulating in the air. In fact, there's good data to suggest you're more prone to upper respiratory tract infections on long flights. Is that what's going on? Maybe, but now with a fever, acute onset. When did she return? Recently. All right, doesn't help me much. Let's say 3 days ago. What else should I be thinking of? PE. Good. Pulmonary embolus. Why? Are you hypercoagulable on planes? Does your blood clot because it's a little cool up there? What is it about planes? It's the immobilization, okay? And there are actually now steps being made on a national level to think about how we could prevent blood clots on long-distance travel, all right? And this is something being addressed on a national level in terms of health, national health safety. Because since we have millions and billions of people flying every year for billions of hours, some people will develop pulmonary emboli, quite a few. Some of those will die. This is a preventable cause of death, if you think about it, okay? Just like on a national level, we could tell people to wear seatbelts. On a national level, we're thinking about, should we tell everybody that on a long flight they should do what? Get up and walk around. Now, it's a little chaotic. You have 240 people walking around on an airplane, but the concept is you want to prevent immobilization, okay? So immobilization is the key here. If you told me that someone just went on a cross-country car trip and they're driving 8 or 12 hours a day, same problem. Someone's been on their knees digging in their garden for 4 hours in the hot sun has nothing to do with it. They're on their knees, venous compression from staying in one position for a few hours, that's immobilization, okay? The key here, a long plane trip, any long plane trip, automatically, long plane trip, patient's about to have a pulmonary embolus, okay? Always say that's about to happen in this question, all right? Now, it might not. The patient might have diarrhea, and it's because they ate bad food wherever they came from, but at least think about airplane, pulmonary embolus. Should be an automatic association in your head, okay? Let's go back to this patient. Vital signs, 99.3. Blood pressure is okay. Pulse, wow, way fast. Respiratory rate, fast, and she's splinting. What does splinting mean? She's sort of she's not doing nice bilateral respiratory effort. One side, it looks like she's trying to protect. Why is she trying to protect that side? Because it hurts when she takes a deep breath. Physical exam shows no oral ulcers or nasal flaring. Oral ulcers. I have to even think about why that's in this question. Oral ulcers and shortness of breath. Oral ulcers and shortness of breath. Well, if you think of something, let me know. Nasal flaring. When do you see nasal flaring? Anybody who's in acute respiratory distress is working real hard, and they're going to take deep inspiratory breaths. And that's one thing you could find on physical examination of respiratory distress, besides the tachypnea. What else could you see? Let's say it's an asthmatic. Nasal flaring is something we comment on. What else? What else tells you a patient has a lot of use of extra muscles, of the accessory muscles? The strap muscles, your sternocleidomastoid muscles. Think about it. When you're bronchoconstricted, what your lungs are trying to do to compensate is get really expanded. So the strap muscles try and pull up your lungs to expand them. So you can actually see these muscles retract, okay? And you can feel the internal intercostals retract. And in a simpler way, you can see nasal flaring. All that indicates is severe air hunger, okay? Trying to get in as much as you can because you're not delivering oxygen to the alveoli, all right? Not specific. The remainder of the examination is unremarkable. So have we thrown out the diagnosis of pulmonary embolus because the exam is normal besides the tachycardia and tachypnea? No. What's the most common lung exam in a patient with a pulmonary embolus? Normal. What's the most common chest x-ray finding in a patient with a pulmonary embolus? Normal. So don't rule out the diagnosis, even if it's a severe PE. You can have a perfectly normal chest x-ray. Okay? Now, we talked about a couple of other possibilities this patient could have. We talked about pneumonia. We talked about asthma. Pneumonia is not likely now. Why isn't pneumonia likely? Well, could this still be a pneumonia? Between the first paragraph and second paragraph, should I make pneumonia lower on my list? Remember, it was number 1 on my list. I put pulmonary embolus up there just because I know she sat still for 12 hours or 18 hours, however long it takes to get from Australia. But what made me drop pneumonia? Her temperature? Well, temperature is a little high. Blood pressure, pulse. Could you have a pulse of 140 with the pneumonia? Sure. Could you be tachypneic? Yes. Do you have a normal lung exam? No. A patient who's sick enough to have pleuritic symptoms and this much tachycardia and this much tachypnea is going to show you something on their lung exam. And if it's an acute pneumonia, it's going to be, quote, typical, and they'll probably have a lobar consolidation on exam. So the fact that this patient is this sick from a pulmonary process, but yet has a normal exam, makes pneumonia unlikely, and in fact, makes me think of pulmonary embolus even more. All right? Now, if this is they say, what's the most likely diagnosis? At this point, I would say pulmonary embolus. If this is a CCS case, what would I do? Well, now, if the patient is this tachypneic and this tachycardic, if you said, put an intravenous catheter in, I'd say, yeah, +1. Never anything wrong. Put the patient on some oxygen. That's probably okay, +1. But I'd rather get an arterial blood gas, take the minute to get the arterial blood gas before I put on oxygen. It might be helpful information. So if I said, draw arterial blood gas, I would get points for that. Now, if I had a patient who came in with a respiratory rate of 16 and had the same story, and the heart rate was 80, and had the same story in terms of Australia, in terms of a negative lung exam, in terms of even some splinting, and I did arterial blood gas with a respiratory rate of 16 and no tachycardia, is that a good thing or a bad thing? It's a bad thing. Right? Arterial blood gas is not a casual thing to order. Arterial blood gas, you're taking a sharp piece of metal and plunging it into an artery. All right? So by definition, you could obstruct blood flow. And if you obstruct blood flow and there's no good collateral flow, you can get ischemia. And it's painful and expensive, but most important, you could do great harm with an attempt at an arterial blood gas. So arterial blood gas is one of those things that can give incredibly useful information, as we saw in the previous case. Tells you pH balance, shows you PCO2, gives you an idea of ventilation, oxygenation. Tremendous information, but at a cost, at the risk of causing arterial injury. So if a patient doesn't look too sick, I don't need to get a blood gas. I don't need to stick a cold piece of metal into a patient's artery and potentially damage that artery. Okay? But in this patient who's tachypnic, quite tachycardic, I think an arterial blood gas is a good idea, and I think you'll get points for doing that on the CCS. All right? If you said, I'm going to put you on oxygen because first I want to get you feeling safer, more oxygen, and then I'll worry about what your pH is and what your PO2 is, I don't think you lose a lot of points for that because it shows that you're addressing your ABCs, airway, breathing, circulation. All right. So here you have several things. I don't think the board's going to ask you, do you put in an IV first or do you get an arterial blood gas? Which would I probably do? She's not hemodynamically unstable. I'm not in a rush to put in an IV. I'm not in a rush to get a blood gas. I'd probably, frankly, what's the best thing to do for her? If you're in ER, you should have a pulse oximeter right next to you. Put a pulse oximeter, put a little plastic clip on her finger, and you'll know her oxygen saturation. If it's 99%, I don't have to worry about oxygen right away. I don't have to even worry about a blood gas. All right? I might still get benefit from a blood gas, even if the patient's well oxygenated, and we'll talk about that in a moment. But again, I would say if this is a multiple choice, if pulse oximetry is there, that would be the quickest, safest way to get valuable information. Because if her oxygen saturation is 85, then the next step is clearly put on oxygen. On the other hand, it's 99%, you have some time to think about what you want to do next. Okay? So again, arterial blood gas, I want to make very clear, it's not something to do casually. All right? Because part of the information you need from an arterial blood gas, you could get with a simple pulse oximeter. And in this day, pulse oximeters are everywhere, and you'll get an accurate reading within seconds. As long as you have the pulse oximeter, within seconds you'll know exactly what the saturation is. Not the partial pressure of oxygen, but the saturation. And that is what translates into what the tissues are seeing. So she has 99% oxygen saturation. I could relax a little bit. Okay? Now, will the oxygen saturation help me distinguish between a pulmonary embolus, pneumonia, bronchitis, pneumothorax? No. Any of these can cause hypoxia, or any of these can cause pulmonary symptoms and not yet cause hypoxia. All right? But what it does tell you is the severity of this pulmonary process. Okay? Does a pulse oximetry tell you anything about a patient's ventilation? No. We say, wait a second. Tell me about saturation. Saturation of oxygen has everything to do with breathing. Yes, has everything to do with breathing, has everything to do with alveolar integrity, with alveolar and capillary integrity, with hemoglobin content, has nothing to do with ventilation. Ventilation, again, is, when used medically, is a strictly defined physiologic term. What does ventilation mean? It means the degree of PCO2 movement, okay, and what your serum PCO2 is. I don't know anything about your ventilatory status by your O2 saturation, okay? You might have, is it conceivable that you could have a patient, try and think of a scenario, we have an oxygen saturation of 85%. I ask you the following question. Is it possible that that patient is hyperventilating and has a very low PCO2? In other words, can you see someone with an oxygen saturation of 85% on the oximeter and on arterial blood gas, that patient will have a PCO2 of 20? Is that possible? Yes. We say, wait a second. He's hyperventilating. He should have better oxygen. Well, that's the point. That person is hyperventilating. You know that because I told you the PCO2 is low. They're hyperventilating because they are hypoxic. All right? And they're trying to compensate by breathing in an attempt to bring in more oxygen. They cannot do that because whatever the pathologic process is, but they're breathing enough, ventilating enough to get rid of PCO2. So that's an example of hypoxemia with hyperventilation. Is it possible that I tell you a patient has an O2 saturation of 85% and I tell you that patient's PCO2 is 60? Is that a possible scenario? Yes. Sure. Patient with a narcotic overdose. They're hypoventilating. That's why they're hypoxemic. A patient with very bad chronic obstructive pulmonary disease, no matter how much they're working, they can still be hypoventilating because they can't blow off PCO2. Their PCO2 rises. And they are hypoxemic for the exact same reason that they are hypoventilating, namely bad chronic obstructive pulmonary disease. So remember, the O2 saturation, you have to think very carefully about what you're ordering when you order a pulse oximeter. All you know about is the patient's oxygen saturation in the blood. It tells you nothing about the underlying disease process. It tells you nothing about their ventilatory status. Ventilatory status only can be known by PCO2. Okay? Now, what would you expect this patient's PCO2 to be? Let's say I put on her pulse ox and it shows 95% saturation. If I drew a blood gas in her and I told you that, what would you expect the PCO2 to be in this particular patient? I'll give you a choice. her PCO2 is most likely to be closest to 60, 50, 40, 30, 5. 30. I would expect this patient who's previously healthy, without any history of pulmonary disease, who has hypoxemia. Remember, 95% is not strictly speaking hypoxemia, but 95% is not 99%. And she looks like she's in pulmonary distress. So I expect her to be working and trying to blow off PCO2 in an effort to get in more oxygen. All right? She has no underlying pulmonary disease, and she's obviously awake and alert and working very hard. So her PCO2 is not going to be 60 or 50 or even 40. I know her PCO2 should be lower than 40. Will it be 5? No, that's exceptionally low. And it's almost impossible to get your PCO2 down to 5, no matter how hard you try. Okay? So I would say in this patient, my guess would be that her PCO2 could be anywhere, 25, 30, 35. And again, you can make an educated guess, but again, that's all that is a guess. Because a patient with COPD who is struggling at 40 times a minute to get in air has a PCO2 of 60. This patient struggling that hard will have a PCO2 of 20. All right, everyone follow. Distinguishing the pathophysiologic features, hypoxemia from ventilation. And the most common, this is where we come to the blood gas, the most common arterial blood gas situation you see in pulmonary embolus is a patient who has, strictly speaking, an increased AA gradient. Typically with a low PO2 and mildly or severely depressed oxygen saturation, and typically low CO2. And what's the physiology of that? Well, unfortunately I don't have two different colors markers. But let's say this is the pulmonary arterial tree. All right? Main pulmonary artery, right pulmonary artery, left pulmonary artery. Let's say superimpose on that the trachea with the right main stem and left main stem bronchi. Okay? If I have a huge clot sitting right here, let's say, does that do anything to her ventilation? No, that's a blood problem. Her ventilation is continuing to go okay, and it can fall. And it will fall because she's hypoxemic. Why is she hypoxemic? Because she is unable to transfer blood from these healthy alveoli with adequate amounts of oxygen. She's breathing room air, she's sucking it in. All right? She's unable to get that oxygen from here into her bloodstream because that bloodstream is clotted off. All right? So there's a problem in alveolar capillary exchange of gas, and that's reflected in a large AA gradient. All right? Ultimately, if the patient gets real sick and have a life-threatening PE, this can be so bad that if this clot is so big, she might not even be able to get the CO2 out of her lungs, and that patient will become hypercapnic. But that is a very extreme case. Far more likely is that the patient with pulmonary embolus is that they will be somewhat hypoxemic and have a low CO2. But even before they become hypoxemic, they will start having a large AA gradient because there's some problem in alveolar arterial exchange. And I could tell you that this patient's blood gas might look like this. Now you look at that gas and you say 90, PO2 of 90, and I'll tell you at 90, her saturation is 98%. Okay? Is this blood gas consistent with what this patient has? Yes. All right? Early on, what you're seeing, even before there's an obvious hypoxemia, you'll see a large alveolar arterial gradient. And what is in this case? It's 150. The alveolar oxygen is 150 minus 1.2 of 30. This is 36. 114. Subtract from that 90. Her AA gradient is 24. Again, we said it should be less than 10. What does an AA gradient increased mean? All it means is, from a pathophysiologic point of view, is that there's a problem in the alveolar capillary membrane exchange of gas. That's all. It could be from a PE. It could be from adult respiratory distress syndrome. It can be from neonatal respiratory distress syndrome. An increased AA gradient tells you one thing. There's difficulty in gas exchange. And that is the hallmark pathophysiology of a pulmonary embolus. With time, yes, this PO2 will probably get worse, and the patient might even hyperventilate more, and this number goes up, the AA gradient. But to start with, the most common blood gas abnormality you see is some mild hypoxemia or no hypoxemia at all, and hyperventilation, resulting in an increased AA gradient. Okay? If this patient was perfectly healthy, didn't have a pulmonary embolus, and was breathing hard enough to get her PCO2 down to 30, if she had no pulmonary process going on, this would be 100, 105. All right? So 90, when you're working this hard, is definitely abnormal, and that can be quantitated by measuring the AA gradient. Okay? So that's what we could tell from an arterial blood gas that we won't know just from the pulse oximeter. Now, the AA gradient will be abnormal whether it's a pulmonary embolus, whether it's a pneumonia, whether it's a bronchitis. Okay? It just tells us a difficulty in gas exchange. Does not help at all in the differential diagnosis. Okay? But don't look at that blood gas and say that's a normal blood gas because, hey, a patient's not acidotic. Who cares about a little alkalemia? That never killed anyone. And PCO2 at 30, okay, it's a little lower than usual. But this, and 90, that's great. Let's go home with her. The answer is no. This tells you there's a problem, and in this clinical situation, you'll worry about a pulmonary embolus. And obviously, a pulmonary embolus is not someone you're going to send home. Okay? Now, let's look at the other possibilities that we list in the differential diagnosis. One is a pneumothorax. Is this a typical presentation of pneumothorax? Can a patient with pneumothorax have tachycardia, tachypnea, splinting, pleuritic chest pain? Yes. Will they have a normal lung exam? No, there's usually diminished breath sounds on that side. But let's say it's not a complete pneumothorax. It's hard to say whether the breath sounds are a little diminished. What else doesn't fit here for pneumothorax? Well, I have no reason for her to have a pneumothorax. Is there any history of trauma here? Did she get stabbed? Did she get a gunshot wound? Did she have an accident where she had a collision of her chest with the steering wheel? No, 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 and no. Is she a very tall, young, thin person who can get spontaneous pneumothorax? Because it is an entity, no, spontaneous pneumothorax, usually young, thin males. I have nothing to make it sound like that. And you're not supposed to guess that somebody has spontaneous pneumothorax. It's a rare enough entity. So what I really want to see in someone with pneumothorax is something in the history to make me think that this patient had a puncture of a lung. Besides the ones we mentioned, maybe a thoracentesis. Okay? That will puncture a lung. Okay. So I don't think that's the case. Pulmonary hypertension, we don't have any chronic history here of right-sided heart failure. Enlarging pleural effusion, well, this is a very acute onset. She has no reason to have an effusion. I don't hear anything that suggests an effusion on my physical exam. Myocarditis, there's no evidence of heart failure here. Doesn't present acutely. That's a bizarre choice. Cardiomyopathy, again, nothing here suggests heart failure of any sort. All right, I don't hear a story of right-sided failure with neck veins, with pulmonary edema to indicate left ventricular failure. I don't hear an S3. These are all essentially nonsensical. What I would consider in this case as pneumonia, but then I get the history of travel and a history of a clear lung exam, not a history, but a physical of clear lung exam, pulmonary embolus goes to the top of my list. So now that we know that this patient probably has a pulmonary embolus, what will I do to make the diagnosis? Here it's straightforward. We want to know if the patient has a problem between ventilation and perfusion. Easy to remember, you want to do a ventilation perfusion scan. How is this done? Patient goes down to the nuclear medicine department. This is one of those reasons you'll get the nuclear medicine radiologist out of bed in the middle of the night. They will come in and they will give the patient two segments of this examination. There's two parts. One is we want to measure the ventilation. So we give the patient air that has been radio-labeled, and when the patient breathes this air in, it will then label the tracheal and bronchial tree. All right? And that will show us the ventilatory side, the ventilation, the V in the VQ scan. I now want to know what the perfusion, don't ask me why Q stands for perfusion, but we want to know the Q for perfusion. We take some blood, label it, inject it, and we watch the blood flow go through the pulmonary artery, right and left mainstem pulmonary arteries. And we'll get back a report from the radiologist that says low probability intermediate probability, and high probability. God forbid the radiologist should actually make a definitive diagnosis and say no chance or definite. You're getting these different levels of clinical utility based upon, in fact, what your clinical suspicion is, okay, in part. What do we mean by that? If your clinical suspicion is very low, for instance, I happen to walk in after this lecture to the emergency room and say, you know what, it hurts when I take a deep breath, I'm coughing, I'm short of breath. They say, what you do all day? I'm walking around on stage, I'm sitting down, I'm running around, I went for a run during my lunch break, and now I'm short of breath. No risk factors, I'm otherwise healthy, I haven't flown anywhere, nothing to suggest pulmonary embolus. And I say, you know what, but I'm really worried about pulmonary embolus. I was lecturing about it, I think about the terrible things that could happen. Please do a ventilation perfusion scan. So they do a ventilation perfusion scan to make me go away. They tell me it's low probability. Now, the sane, intelligent doctor says, you know, Kornbluth, you're paranoid, you're crazy, you don't have a pulmonary embolus. I say, well, the scan says a low probability. Maybe there's still a chance. But the doctor's clinical suspicion is that I have very little chance or no chance of having a pulmonary embolus. Then that low probability VQ scan is as good as saying you don't have a pulmonary embolus. On the other hand, let's say a 600-pound patient who had hip surgery yesterday and has had 3 previous deep venous thromboses in her legs in the last 2 weeks, who's been laying in bed since her surgery, and before that was laying in bed for 2 weeks before that, developed sudden onset of pleuritic chest pain, and tachypnea, and tachycardia, and a normal lung exam. And I have very high suspicion, clinically, for a pulmonary embolus, and I get back a low probability on that 600-pound immobilized, hypercoagulable post-operative patient. Even with a low probability, I'm not going to say that there's no chance that there's a pulmonary embolus. I'll say it's low probability, but my clinical suspicion is so high that maybe I'll do another test like a pulmonary angiogram. So you have to interpret the result of the VQ scan in context of your clinical suspicion. All right? So low clinical suspicion with a low probability VQ scan tells you that the patient probably doesn't have a pulmonary embolus. On the other hand, this patient has a pretty high clinical index of suspicion for pulmonary embolus. She has the history for it. She has the physical exam, meaning tachycardia, tachypnea, normal lung exam. I showed you abnormal AA gradient. My suspicion is moderately high. So if she had a high probability, I would say you definitely have a pulmonary embolus, and I would start treating her. And so there, you have to weigh not only the results of this VQ scan, but the results of what your clinical suspicion is. And you run into problems, obviously, when you have intermediate probabilities. Okay? But the board is not going to ask you what to do with an intermediate probability in a patient in whom you have a intermediate level of suspicion. They'll give you someone with low probability, with low index of suspicion, or high probability with a patient who you're pretty sure has it. On the other hand, if there is that disparity, you think there's an excellent chance the patient has a pulmonary embolus, but yet the VQ scan comes back that it's low probability, in that case you really do have to go to a pulmonary angiogram to confirm the diagnosis. Because we want to start treating the patient for a pulmonary embolus, and the treatment for a pulmonary embolus has a lot of risk. So if we do a ventilation perfusion scan, and we get the result back high probability in this particular patient, this patient who flew back from Australia, otherwise previously healthy, no history of hypercoagulable events, what will we want to do next in this patient? Patient is in the emergency room, and you did a ventilation perfusion scan. Let's say you're in a CCS mode now. You typed in order ventilation perfusion scan. And it says patient returns from nuclear medicine 2 hours later. The report is high probability for pulmonary embolus. What do you do now? You anticoagulate the patient. So you write anticoagulate the patient. And it says the software does not recognize your order. What are you going to say? Be a little more specific. Anticoagulate? Am I going to give the patient aspirin? What am I going to give the patient? Heparin. So you write heparin. They'll say, okay, what route? Sub-Q? Orally? There's no oral. There's an experimental form of oral. Sub-Q, IV, IM, suppository. What kind? IV, intravenous heparin. Okay, this is step 3, not step 2. Please submit your rate of infusion Or please specify dose and rate. What's a reasonable way to start heparin? We generally bolus the patient with, say, 1,000 units. They say, give patient intravenous bolus of heparin. What dose? 1,000 units. What do you do next? Start intravenous heparin infusion. What rate? Usually about 1,000 units per hour. And then we will make adjustments in our rate based upon what parameter. Intravenous heparin is started. The patient is now in the hospital. You admitted the patient, or maybe not. Maybe the patient's still in the emergency room. The patient is now receiving intravenous heparin after your bolus is on 1,000 units per hour. What is your next step? You're very proud of yourself. You made the diagnosis. You sent the patient for the nuclear medicine scan. They confirmed your diagnosis. You started the patient on what you know the appropriate therapy is. Computer won't leave you alone. They're harassing you. The computer's harassing you. What are you going to do? What do you do now? All right, you're going to move the clock. Remember, you have to manage time. Let's move the clock to where? I want to see the patient when? Tomorrow when I make my morning rounds? In the office? Where? I don't care where, but the patient's going to stay in the hospital. So I'll say, admit patient to intensive care unit. No, this patient's hemodynamically stable. She's tachycardic. She's tachypneic. Her arterial blood gas doesn't look too bad. I say she could go to a general medical service. When do you want to see the patient again? Tomorrow morning. Let's say, well, it depends what time it is now. Let's say it's 2 in the afternoon now in the emergency room. Patient's now in heparin. She came in a few hours ago. It's now 2 in the afternoon. What do you want to do next? Well, I don't know if I have to see the patient in 4 hours, but what do I want to do in about 4 to 6 hours? Check her blood test to make sure she's getting the right dose of heparin. So you'll write, check blood test. They'll say, which blood test would you like, doctor? What would you like? You want a PT and PTT? Okay, I'll give you +3. I'm being very much a purist now. What do I really want? Just a PTT. Because you write PT, I mean, I'm getting picky now. You're not going to lose points, and as you know, most labs, when you write PTT, it's because they give you the PT also. But are you looking for a PT effect? Are you looking for the INR? No. You're looking for the PTT. Because what's the effect of heparin on the coagulation cascade? It affects the PTT. And if you just wrote PT or INR, you'll lose points, for sure. All right? So you want a PTT, partial thromboplastin time. Okay? So send partial thromboplastin time. The blood test returns 1 hour later. The partial thromboplastin time, the control is 30 seconds. Your patient's PTT is 39 seconds. What's your next step? Increase the heparin. All right? Now, there are different ways to approach this. You could say, well, I'll give the patient another bolus and increase the hourly rate. Most people these days, rather than give repeated boluses, will just increase the hourly rate. So say, okay, I'll go from 1,000 units per hour to 1,100 units per hour. What do? Come back in 4 to 6 hours, check another PTT. All right? And so where do I want the PTT? Obviously, I'm making this dose increase because I wasn't happy with the PTT of 39 seconds. Where would I rather have the PTT? 1.5 to 2.5 times control. All right? So if your PTT is 30 seconds, 1.5 to 2.5 is 45 to 75. 60 seconds would be perfect. Okay? And I'll make dose adjustments in that range. Okay? Computer says you made your dose adjustment. 6 hours later, the PTT is now 60 seconds. Computer won't let you go. What do you do next? See the patient the next day. They say, okay, the next day the patient looks far more comfortable. She's no longer tachypneic. She's no longer tachycardic. A repeat partial thromboplastin time, PTT, in the morning is 62 seconds. What do you do? All right, so I want to start my long-acting anticoagulant, namely Coumadin. Why didn't I try and save a day and start Coumadin right when I started the heparin? Because theoretically, if I give Coumadin before the patient is adequately anticoagulated from the heparin, Coumadin's first hematologic effect is actually to make the patient hypercoagulable. And if you remember step 1 and step 2, not only does Coumadin inhibit factors, what factors? 2, 7, 9, and 10, the vitamin K-dependent factors. It also inhibits protein C and protein S. And its earliest effects are on protein C and protein S. If I inhibit protein C and protein S, I become hypercoagulable. All right? So until I see the full anticoagulant effect of Coumadin, the first thing I'll see is hypercoagulable effect. Obviously not something I want even for a few hours in a patient who just had a pulmonary embolus. So first thing I do is get the heparin on board. That I should be able to make the patient therapeutic within 4 to 6 hours. And then I could think about giving my patient Coumadin once I know the patient is adequately anticoagulated with heparin. Okay? So, I start the patient on Coumadin. What do you do next? Okay, so next morning I come back, patient looks comfortable. The PT is, how much Coumadin would you like to give? So start oral Coumadin. What do I want to do next? Order a ProTime for the morning. ProTime and INR. What do I want my INR to be? Roughly 2 to 3. Okay? That's not a question, that's a statement. 2 to 3, that ballpark. Some people say 1.5 to 2.5. Clearly, if your INR is 1.2, it's too low. If it's 4.5, it's way too high. Okay? So you're going to get the patient's INR to 2 to 3 and make the appropriate daily dose adjustments in Coumadin to achieve that. Okay? Okay, so now 3 days later, the patient feels fine, is breathing comfortably now for days. The PTT is 67 seconds. The INR is 2.5. What do you do now? Discharge patient home. Okay, the order is entered. The patient is preparing to go home. What do you do now? Well, stop the heparin. Patient's anticoagulated on Coumadin. I could stop the heparin. Patient doesn't need 2 anticoagulants at once. And what do? Patient's going home. Well, interns need to know who's going to follow that patient, how that patient's going to be followed. Step 3, you have to know what the follow-up is going to be after they leave the hospital. Where are they going to go? Home, see you in a month, see the pulmonologist in 2 weeks? The answer is schedule patient to have INR in, make up an interval, 3 days, a week, 2 weeks, tops, but not send the patient home with follow-up in a month from now. You want to check that INR is an outpatient. Make sure the patient's taking the right dose. And see the patient in the office in the next couple of weeks. All right? You don't need to see the patient the next day. I wouldn't wait 6 months. Few weeks. And then make sure the patient has an INR checked on a regular basis. They won't ask you should it be every week or every month. Usually once they're stable, we do it every month or so. If they're on it for a long time, we might do it less often. That brings us to the question of how the patient asks you, doctor, on your first patient visit, patient looks fine, INR is 2.2. Patient says, doctor, how long will I have to continue the Coumadin? Type in a time interval. The answer is 3 to 6 months. Because this patient does not have some underlying tendency to form pulmonary emboli. She had a clear external reason. She had a plane flight for 18 hours. If she's not flying again, she no longer has a potential high risk of pulmonary emboli from DVT. So I would say I would treat for 3 to 6 months. On the other hand, it turned out that this was one of multiple pulmonary emboli, and I determined that the patient turns out to be hypercoagulable. That patient will need to be on Coumadin for life. So the answer is how long to anticoagulate the patient after a deep venous thrombosis of the leg, which is after all where this pulmonary embolus started, is a big vein in the pelvis or thigh. The answer is if it was a single event with a clear explanation that is no longer present, you treat for 3 to 6 months. If the patient has some underlying malignancy or some underlying hypercoagulable cause, then you'll need to treat the patient for a longer period of time. Okay? On rare cases, only on rare cases, will you have to proceed beyond your anticoagulation and use thrombolytic therapy in your patient with a pulmonary embolus. And again, this is fortunately an infrequent occurrence, so I'm not going to spend too much time on it. But in what kind of pulmonary embolus patient would you imagine that you would take the huge risk of thrombolytic therapy? Who would you take that risk in? Would you take it in this patient with this kind of clinical picture, expose it to the risk of intravenous thrombolytic therapy and the 1% risk of major intracerebral hemorrhage? No. If I'm going to expose somebody to the risk of thrombolytic therapy, if I think that heparin is not good enough, that they need thrombolytic therapy, I better make sure that the benefit outweighs the risk. And the benefit being, if I don't give it, the patient might die. So I'm not going to use thrombolytic therapy unless I have a potentially life-threatening PE. What constitutes a life-threatening PE? Do you make a determination of a life-threatening PE based upon the size of the blood clot seen on perfusion scan? No. You make the determination based upon two factors. Does the patient show you intractable hypoxemia? In other words, no matter how much oxygen you deliver, even on a respirator, the patient cannot oxygenate because they probably have a huge clot obstructing the entire pulmonary artery. That patient, you better lyse that clot, or else the patient will die of hypoxemia. The other situation is when this clot is so large that it causes acute pulmonary hypertension, and the patient can get hypotensive. That patient requires thrombolytic therapy. So the two indications are refractory hypoxemia, despite no matter how much oxygen you give the patient, and acute right-sided heart strain resulting in hypotension. Those times I'll expose the patient to the risk of thrombolytic therapy, followed by my heparin and then Coumadin, and get the patient home as soon as possible.